the PG clinics under the Indian Academy of Pediatrics. Last time we had Professor Shankar Narayanan having a wonderful session. This time there will be a case discussion of a cardiovascular system case. This will be presented by Dr. Shruti, and the discussions will be me and Dr. Jnana Sambandam, Professor of Pediatric Cardiology at our hospital and also the Institute of Child Health. This webcast is possible because of the support given by OCOT Vaccines. This is discontinued for some time. We have restarted. Last 1 month it is going on very successfully. Let's hope we'll have a very good discussion on this. Over to Dr. Shruti.
Good afternoon, sir. This is Venkatesh, a 10-year-old boy hailing from Kanchipuram. The informant of the case, clinical history, is his mother, and the history is reliable. Venkatesh is a known case of heart disease, now presenting with increased exertional dyspnea for the past 2 months, and complains of right knee joint pain while walking for the past 2 months. We go on to the detailed history. Venkatesh is a developmentally normal child who first presented 2 years back with complaints of increased pulsations over the chest wall, which was felt by the mother while picking him up. At that point of time, he had no history of chest pain, no history of any respiratory distress, no history of any palpitations or increased feeling of his own heart pulsations. There was no history of any preceding sore throat, no history of associated rash, joint pain or any joint swelling or involuntary movements, no history of any painful nodules on the palm or any history of prolonged fever, no history of any epistaxis or abdominal pain. He has no history of any similar complaints in the past, no history of any complaints suggestive of a congenital onset like bluish discoloration of lips or extremities.
Shruti, sorry for stopping you.
Yes.
What are the primary symptoms? You said so many no history.
So his parents say that he has a heart problem, presenting with complaints.
What symptom was the first symptom
of
that you said the parents noticed?
Increased pulsations over the chest,
Increased pulsations.
which is noted only by the mother when she was picking up the child
When was that noticed?
2 years back.
2 years back.
But
He's a 10-year-old, isn't it?
Yes.
8-year-old, where is the question of an 8-year-old boy being picked up, and is it likely for that a 8-year-old boy is picked up by the mother?
10 years is only 20 kilos, so I'm guessing he's really...
Even that, how often does a mother carry a 8-year-old child and identify pulsations?
She very clearly gives the history of saying, when I was planning, I was trying to pick him up from the bed, I felt his pulsation. A very clear history like that.
Where was the pulsation felt?
She felt it over the chest, on the left side.
Left side, lower, upper, middle?
She doesn't feel like that.
Is it important?
Depending on the area.
Is it important to know where the pulsations were perceived by the mother? And if so, how and why?
So precordial pulsations as such could have been a parasternal heave or otherwise can be...
What are the situations in which a mother perceives pulsations in the left side of the chest? Or for that matter, what are the situations in which a mother perceives pulsations in the chest by and large? Can you tell me a few situations where a mother perceives pulsations in the chest wall of any child?
The tachycardia can be due to fever, can be anyhow high output.
The commonest is tachycardia, isn't it?
Yes.
Commonest is
Tachycardia.
when the heart is racing, always it is felt as abnormal by the mother. That is the commonest. Is this tachycardia in this child? So how do you know the pulsation that is perceived is tachycardia?
Any associated complaints like fever or
Anybody from the audience? And the mother will say it is beating fast, and she will say that it is a prominent pulsation. Isn't it? That is tachycardia. She will tell you it is racing. That is one. What are the other conditions in which you get prominent pulsations in the chest wall, other than tachycardia?
Cardiomyopathy.
Anybody? Yes, Sangeeta.
Things
I hope your heart doesn't beat faster on the question. Malnourished? Is that very common, a malnourished child? Can you give an example of
anemia,
commonest, if you
thyrotoxic.
ask me, a child with anemia, definitely there will be a hyperdynamic circulatory state, the pulsations may be more prominent. 2, 3,
Hypothyroidism.
pardon? Anything, yeah, A, B, C, D, right? Anemia, beriberi, thyrotoxicosis, coarctation, etc., right? Then,
Any cardiomyopathy?
okay, cardiomyopathy,
Any arrhythmias?
arrhythmias, yes. And they, again, tachyarrhythmias to be specific. Anywhere else?
Right ventricular hypertrophy, parasternal heat.
Yeah, a parasternal heave can be felt to be a pulsation by the mother as abnormal, quite rightly. Anyway, anything else? Yeah, cardiomyopathy, cardiac failure, right? Anywhere else? Aneurysms, very uncommon in pediatric age group, but however it has to be kept in mind. Anyway, anything else?
Increased collateral.
Pardon?
Increased intercostal collateral.
Anything else? So, okay, the heart is normal, but pulsations are abnormally felt by the mother. Heart is normal, but the pulsations are felt abnormally by the mother. In other words, heart is functionally normal. If a child has got a dextrocardia, the mother might even give you a clue, I am feeling the pulsations on the right side, but otherwise my child is okay. Yes or no? She will give you the diagnosis if you take history. Right? Sometimes, if you have very severe chest deformities, I am doing something. Can you get the clue for that?
Scoliosis.
Yeah, when there is kyphoscoliosis, what will happen to the apex? It will be pushed forward, isn't it? Pushed forward, sometimes laterally or sometimes medially. And any child with a chest deformity may be perceived to have abnormal pulsations. Yes or no? Right. Anywhere, anything else? Outside the heart, we mentioned something in the lung. Anywhere down? Sometime a child with a
Hernia.
hepatomegaly, for example, a tricuspid regurgitation, or massive right ventricular hypertrophy, mother might perceive there is a pulsation in the epigastric region. Epigastric region. Of course, rarely when you talked about aneurysm, it's aneurysm of the abdominal aorta. Sometimes here it is in the neck, and sometimes even the Corrigan sign. What is Corrigan sign?
Dancing carotid.
Dancing carotid may be perceived as pulsation by the mother.
Sometimes pulsations.
These are all situations where a mother might feel that there are abnormal pulsations. So when Shruti said pulsations, she must be more clear what she is meaning. What is your interpretation of the pulsations mentioned by the mother? Which of the discussed possibilities is the cause for the pulsations in this child?
Sir, it was increased precordial pulsations. Increased pulsations felt on the left side of the chest.
Yeah. So which of the causes is responsible in this child? You said so many negative things.
Yeah, I could have probably said no pallor noted. He had fever at that point of time. Could have been tachycardia because of fever. But otherwise, thyrotoxicosis I have not ruled out. I directly went into thinking because it's in the left side chest, it must have been a probable underlying cardiac condition.
Okay. So you think it is due to a, here in this child you think it's due to a
Probable cardiac.
cardiomegaly. What do you think is caused? Sometimes even a pulmonary hypertension, the mother may perceive pulsations exactly in the second space. So you must have gone into depth about what the pulsations are. Instead of saying, I mean, not that I am criticizing you, they're mentioning so many negative things. The first statement she made was pulsation. After that it was all
Negative.
negative. I think you should avoid doing that in the presentation. What will happen? If you do like that, the entire first statement will get diluted. You get my point?
Yes.
Instead of that, you qualify that statement. What was that? What was that?
Sir,
In fact,
if I put it like he first presented 2 years back with complaints of increased chest pulsations noted on the left side of the chest by his mother when he was trying to pick her up. But she says immediately she went to the doctor for it to be evaluated and was told that there is a disease of the heart valve, in the mother's words.
Okay. Always reserve the mother's concept and the diagnosis made at the end of your presentation. Otherwise, you will be wrongly biased towards a wrong diagnosis. Right? Fine. Go ahead.
I went on to say that there is no history suggestive of any other
Nothing else is there. You mentioned so many negative things. Okay.
no history suggestive of any congestive cardiac failure, no history suggestive of any infective endocarditis. I tried to rule out any other major or minor criteria involved in probable rheumatic heart disease, rheumatic fever, and I went on to rule out if there is any previous history of congenital heart disease. For the above complaints, she was evaluated and found to have a valvular
Was
problem.
there any difficulty in breathing, shortness
No,
of breath?
she does not. She very clearly says 2 years back had no complaints of dyspnea.
Yeah.
Her dyspnea
How
started-
can you take it? Like, is it you need to reassess, or
We need to reassess because
yeah,
something
it's very unlikely to
as-
have just
yes,
abnormal pulsation without any other cardiac complaints
problems.
in a cardiac case.
But even
Um,
on repeated asking, she says no dyspnea. Even on excursion, his dyspnea complaints start only 10 months back.
Just to clarify, I think suddenly I thought of, I just wrote down, sometimes in any cardiac symptom, a mnemonic which my old teacher used to say becomes very useful. For example, the mnemonic is chloride, CLORIDE. It's very simple. Don't write down, you just understand. Since it struck me, because she omitted that, I'm just trying to stress that. One is the character. When you say pulsation, the character will also give you a diagnosis. For example, whether it is a parasternal heave or whether it is a pulmonary artery pulsation, the type of pulsation will give you, if it is lifting, you know it's a right ventricular hypertrophy. If it is only a pulsation, you know it's an arterial pulsation. So character. Second is the location. Location means whether it is left, right, center, up, lower, down, second space, fourth space, or in the apex. Sometimes you may even get a pulsation in the apex. It may tell you a clue that it is a hyperdynamic apical impulse. Location. Third is the onset. Onset. How is the onset important? It tells you whether it is acute or chronic. Shruti, she noticed it insidiously or insidious. Fourth is radiation. Radiation. Whatever that is happening, of course in a pulsation you are not going to say radiation, you are not going to see a wavy thing, but sometimes even that could become important if the pulsation in the neck is seen which is going up, right? And then I is intensity, any symptom, it holds good for any cardiac symptom. Intensity, severity of chest pain, severity of dyspnea. D is duration, how long it is there. And E is exacerbating or alleviating factors. So I think this mnemonic is very, very useful when you inquire into any cardiac symptomatology. Chloride, no H, CLORIDE. Very, very useful. You can apply this to any cardiac symptom that the child has.
And also, when you have an onset, you also have an offset. Arrhythmia will be a rapid offset, whereas a CCF symptoms will be gradual and offset. So when you have a gradual onset and a gradual offset, it's going to be more of a CCF for other reasons. If it's going to be arrhythmia, it's going to be rapid onset, rapid offset.
For the above complaints, he was evaluated and found to have a valvular heart problem and started on oral medications to be given twice daily continuously, a probable penicillin prophylaxis. Over the next 1 year, he had complaints of occasional dyspnea on exertion, but was otherwise asymptomatic. Mother does not give a consistent history. Occasionally, she says when he plays, he has dyspnea, otherwise not specific. 10 months back, he developed complaints of edema of the lower limb and face. This was not associated with any complaints of chest pain or dyspnea, no abdominal distension or decreased urine output. Following this admission, he was started on additional medication that was given once daily for 5 days a week, probable digoxin. He was not started on any other anti-failure drugs along with this.
Where do you say digoxin probable?
5 days a week, sir, with 2 days off.
Is it recommended nowadays?
No, not, but she says any other medication.
It's no longer recommended as 5 days a week. Occasional dyspnea, is it common? It's going to be like when you have a certain amount of activity, the child gets into dyspnea.
Yeah. She doesn't give a consistent history of dyspnea on exertion.
Again, that history has to be reassessed and retaken.
Over the past few months,
1 minute. What do you mean by occasional exertional dyspnea? What is the severity of dyspnea? Please explain the adjectives you have used.
Exertional dyspnea.
What do you mean by occasional? What do you mean by exertional?
Exertion is occasional was a mistake on my part.
What is exertional?
Exertion is.
Suppose I climb to the 6th floor right now. If I get dyspnea, is it exertional dyspnea or not?
It is.
It is. So, what exertion brought about the dyspnea? Why is that important? Why is that important?
It grades dyspnea. You can grade.
Yeah. So, what is the grade of dyspnea?
He
Yes,
had
grade when you come.
he had
give
grade
the
4.
present-
What is the reason and rationale for grading dyspnea? Why should you do it? Is it just for theory class or for
it gives you an
discussion?
extent of his. You can grade his.
Anybody in the audience? Why should you grade it? Objectively follow up the severity. For example, a child who is having grade 1 dyspnea moves to grade 2, you know the disease is
Progress.
worsening and vice versa. Right? So, objectively monitor the severity of symptoms. Right? How do you grade dyspnea? Do you use objective methods? How do you grade dyspnea?
Dyspnea. Grade 1 is no dyspnea, and grade 2 is.
No dyspnea. Can a human being live without dyspnea at all?
What classification you use? Proper name you use? You have different classifications.
NIHA classification.
Which is the most easy and practical classification?
NIHA, New York.
Easy to remember 1, 2, 3, 4. 2 is ordinary, 1 is extraordinary, 3 is less than ordinary, 4 is at rest. This is the easy way. I don't know whether a specialist will approve that this is for a generalist like me. Easy way. Grade 1, easy way to remember. Grade 2 is ordinary exertion. For example, Shruti climbing up 2 stairs from first floor to 3rd floor is normal. If she becomes dyspneic is abnormal. Right? Grade 1 is extraordinary. Me trying to go to 6th floor in a hurry. Yes, it's extraordinary. Very, very fast if I do it. Or I climb the hill. Footsteps of Tirumala hill. Extraordinary. Grade 3 is less than ordinary. For example, from here I move to the downstairs reception. If I get dyspnea, it is grade 3. Grade 4 is at rest. At rest. This is the most easy way to classify. Of course, there are maybe other classification. This is most easy. Because for every age you can always define what is ordinary. For example, ordinary for a young infant is breastfeeding. Ordinary for a school going child is to walk to the school or cycle slowly. So you can define based on the age. After all, it varies. So this is the easiest way. In what grade of dyspnea did this boy start with the symptoms?
Sir, he was already at grade
You said occasional exertional dyspnea. That's why I'm asking you.
After playing for some time, he did like
After playing for how much time?
15,
What
20
game?
minutes.
What game? It's very important.
Yeah, degree of exertion is class.
Yeah, what degree of exertion brought about the breathlessness?
Running around and playing with other boys. Then he, after some time, he prefers
So
to
that
sit down.
becomes what?
Grade 1 severe exertion.
Grade 1 is extraordinary, ma. Grade 2. Grade 2. And what is the dyspnea now?
Now he's progressed to grade 3.
See, now it becomes important. So from grade 2 it has slowly progressed to
Grade 3.
grade 3. Then other thing is, again you have to apply for dyspnea also the same chloride mnemonic. Whether it is persistent, how did it start, insidiously, all that is important. Please go ahead. Again I am repeating, please don't concentrate on what the mother has been doing with 5 days of medicine, orange color medicine, yellow color medicine. I think that's less important than describing what has happened to the chronology of events, right?
Over the past few months, he has been complaining of progressively increasing dyspnea, which is initially he would complain of dyspnea after running around and playing for around 15 to 20 minutes, which now he complains of dyspnea even on walking. He does not climb stairs because of dyspnea, but and it settles down after sitting down for some time. He does not have any complaints of dyspnea at rest or on lying down. No history of waking up from sleep with respiratory distress.
So anyone can become dyspneic on severe exertion. How do you differentiate that from a pathological dyspnea? And normally we run and we become dyspneic. We have a congestive cardiac failure, mild failure, we run and become dyspneic. How do you differentiate both? How long it takes to come back to normal? It's prolonged, it's going to be pathological.
2 months back, he developed complaints of joint pain in the right knee joint while walking to school. It involved only the right knee joint. It was not associated with any swelling or redness. He had no history of any preceding sore throat, fever or loose stools. No history of involvement of any other joints. He was able to sit in the toilet, walk around, but there was no limitation of movement, but he had a constant pain. There was no associated rashes. For the above complaints, he was started on medications, and his joint pain subsided soon after.
Now, how long did the joint pain last?
2 to 3 days.
Did it subside with medication, without medication?
With medications, it subsided within 2 to 3 days, is what she says. So it's more like a rheumatic knee involvement.
Is it more likely a rheumatic involvement?
Yeah, and no history of any early morning stiffness also. So
now, what is typical of
rheumatic
arthralgia?
involvement? It subsides with NSAIDs. If you start medications, it subsides fast.
Is it a single joint?
Only a single. It is not migratory.
No, typical of a rheumatic. Is it
typical is migratory polyarthritis. It involves one joint for a week, for a few days, and then moves on to the other joint, and completely subsides in the first joint, involving the major joints, knee and ankle, elbow and wrist, and it subsides with NSAIDs.
But a single joint involvement is it taken as a typical?
It is a typical of rheumatic.
And nowadays with recent modification in the Jones criteria, even monoarthritis, no arthralgia, it's monoarthritis. It has to be inflamed in a high risk patient, typically in a Indian subcontinent.
This is-
Monoarthritis, not arthralgia. You
This
just
is an
put it as
arthralgia.
arthralgia. It's even by your latest modification, it doesn't fit into rheumatic etiology.
Sir, minor
It has to be
criteria?
arthritis. Arthritis is with inflammation. Arthralgia is without inflammation.
So
In fact, though Shruti said this is history typical of rheumatic, I would say that this history is very, very inconsistent to the diagnosis of
rheumatic.
a rheumatic fever.
Yes.
There are several things which are not fitting into rheumatic. One is that it is an arthralgia. Second is that it is a single joint. Third is that there has been no fever at all. Fourth is that there is no preceding sore throat. So, with this history, you can't say it is typical of rheumatic arthritis, right?
Someone
What
said
is
polyarthralgia you said. Polyarthralgia is included and monoarthritis is included. No monoarthralgia. Okay.
He has no other significant past history. Birth history is normal. He is well immunized for age. According to the Tamil Nadu government schedule, no other optional vaccines were given. BCG scar is present. Development, he studies in 5th class, has a good scholastic performance. He interacts well with his peers. No bowel and bladder abnormalities, gets adequate sleep at night. Diet history, he has a calorie deficit of 1200 calories and 4 grams of protein. Family, he is second born to a 3rd degree consanguineous marriage. First child is a 13-year-old girl with no significant issues. There is no history of any cardiac complaints in the family, no history of any hypertension or diabetes mellitus, no history of any COX contact. Socio-economic history, parents are both 9th class pass, work as manual laborers. They stay in a 2-room Pakka house with poor toilet facility. They are a nuclear family, staying in 2 rooms, hence no overcrowding. They belong to the upper lower class family according to Kuppuswamy scale.
what is the definition of overcrowding? You said there is no overcrowding. What is the definition of overcrowding? When do you say, for example, is this room overcrowded now?
Yes.
How do you define objectively overcrowding?
No people, no two above the age of 7 years, brothers and sisters are supposed, even if siblings are supposed to sleep in different rooms.
Okay, 9 years.
9 years.
In the same room, 2 persons cannot remain in the above the age of 9 years. The WHO, that is what has defined. I believe for overcrowding there are definitions for European Union, for other countries, etc. But WHO says it is above 9 years, 2 persons, male or female, opposite sex or same sex, should not be staying in the same room. Of course, the room size also they are given. I don't remember. Anybody remember the room size? I don't know. Not necessarily. More, huh? Yeah, some criteria for the area is not. So, why is overcrowding important? It's said to be epidemiologically important for spread of
Rheumatic.
streptococcal sore throat and important epidemiologically for your rheumatic fever.
And calorie deficient is nearly 1200 calories, but protein is just 4. Is it proportionate like? Okay. Carry on.
Which part of the history is deficient from the audience? She has completed. You have completed the history,
Yes.
isn't it?
Yes.
Yeah. Any deficiencies? Anything you would have done extra? Of course, she did present well. Anything else you would have done extra? Ishita, you also saw the case, no? Yeah. What was missing in the history? Pardon? One thing, remember 2 things. Of course, she mentioned tablets being given. 3 things were missing. 1, what has happened to the schooling of this boy? He has a chronic disease. This is going on for quite some time. How has his lifestyle, schooling, day-to-day activities been affected by the disease? That is number one. Number two, is he growing well or not? Right? I never heard anything from Shruti about the weight gain of the child and about the height of the child. I mean, it's not necessary you must give kgs and centimeters, at least in comparison to other children. Number three, the medications that the child has been on, and more so, in this child, what medication particularly you will be interested in knowing with regard to the prognosis of this child? How compliant are
area. Pulmonary area, allowed P2 is heard, and a grade 3 by 6
No,
soft.
you always related to inspiration, expiration. And
That's
it's not
not
the
it.
same murmur, it's a different murmur.
Yes, sir, where?
Your apical and the lower,
Left sternal border.
it's a different murmur. Increases more with inspiration. Okay, you carry on, we'll just go on to the findings.
Pulmonary area, allowed P2 is heard, grade 3 by 6 soft blowing ejection systolic murmur is heard. I don't know, best heard with the diaphragm. Aortic, both first and second aortic areas, S1, S2 sounds are heard, no murmurs. Per abdomen soft.
what is second aortic area?
It
Is there an area called second aortic area?
third left intercostal
It's no
space.
more use. The term is not used. Should only say third, fourth space. Not accepted. Standard clinical books these days don't mention second aortic area. It's a misnomer.
But aortic events are heard in the third left intercostal space, because the aortic area comes like this, whereas pulmonary area comes like this. Mitral area is localized here. Mitral area is localized here, tricuspid area is localized here. Whereas these two areas, there is an extension. Aortic, it's like this.
So I won't say second. Per abdomen soft, not distended. Liver is palpable 4 centimeters below the right costal margin. There is no spleen palpable. Respiratory system, no tracheal deviation. Precordial bulge is present with a visible parasternal heave and apex beat. Visible pulsations are noted in the suprasternal region. No dilated veins. Bilateral air entry is good. No basal crepitations or rhonchi. CNS, no neurological abnormality detected.
Abdomen?
Soft, not distended, no free fluids. Liver palpable, no spleen.
Liver how much?
Liver palpable 4 centimeters below the right costal margin. Soft.
Always give the liver span.
I just
It can be a push down liver.
I had written it, but I forgot to mention it.
And in any cardiac, more so with the congenital heart disease, you always mention liver is on the right and the tympanic resonant on the left. And also, how do you palpate the apex? Can you demonstrate how you palpate the apex? No, you palpate, don't ask them.
Where can I make him lie down? அம்மா இங்கே உட்காருங்க. பாப்பா இங்கே படு பாப்பா. படுடா வா.
Even in sitting posture, you palpate the apex. Like, just wanted to see the procedure you. Yeah, this is what is not to be done.
Okay.
It can be a dextrocardia. You are just concentrating on the
Okay.
left side. You always go like this.
Okay.
Localize the pulsation. Then you go concentrate on the side where you.
Then fingers on the chest like this, so that you don't miss the dextrocardia.
Dextrocardia should not be mixed. More so with your congenital heart disease. Even a rheumatic heart disease can occur in a dextrocardia. So always first sight test, then you go to the finding. So elaborate on the auscultation. Just highlight on each auscultatory finding.
Mitral area has a loud S2. I'm not sure. He has a loud heart sound, single heart with a pansystolic murmur.
You said loud S1.
If I will say it's a loud S1, I can collaborate it with the presence of a mitral mid diastolic murmur. I can say there's a stenosis along with the regurgitation.
Is it a loud S1?
Opening.
Anyone else can auscultate and just comment on the heart sounds. The person who had seen it earlier. You had seen, no?
Can we say it's an S3? So loud, very loud. Backwards.
There are two findings in inspection which definitely arrest your attention. Can anybody tell me what findings, which of course Shruti did not mention? Is this boy comfortable? Is this boy comfortable, or is he having respiratory distress? How do you identify? How did you? Yes, definitely got significant intercostal retractions. At rest, he is standing, can see the intercostal retractions, number one. Right? Number two, does he have a chest deformity or not? What chest deformity? Huh?
No, he's got a scoliosis.
Is his sternum projecting forward or not? What do you call that?
Rectus carinatum.
Okay. Of course, with an asymmetry of the left side of the chest. And one more finding, if you can lie down somewhere.
Did you mention the respiratory rate? How do you count the respiratory rate? Can you give a demo?
You make him lie down, stand at the foot of the wall and see his chest rise, or you can keep a palm on his chest and look for rise of your hand.
You
Now,
put your finger.
what is the procedure to see the respiratory rate? Just see the respiratory rate in this child. Count the respiratory rate in this child.
இங்க வா கொஞ்சம் ஸ்ட்ரைட்டா படு நேரா படு
Okay. The thing is, you palpate and see the watch. You don't just see the abdomen, and you can't be watching both your watch and your abdomen. You have to palpate, see the rise. I mean, you feel the rise, and then have a watch on the. I mean, you look at the watch for 1 minute. Okay. So you see the respiratory rate. What is the heart rate here?
100 per minute.
Is it just 100? Can anyone of you just auscultate and or tell me the heart rate here? The child is symptomatic at rest. Could it be 100? And what is the respiratory rate? And what is the implication? So heart rate you can count for 6 seconds.
So 6 or 15?
6 is,
Fine.
I mean, for your practical purpose, 6 is okay. 6 seconds. Okay. Respiratory rate. Respiratory rate has to be counted for full minute. Keep discussing. Later.
Basically, in an older child, you need not have to put your hand on the abdomen. You can observe. In an infant, it may be required, particularly if it is breathing fast.
Why hyperventilating?
Her respiratory rate has gone up. Relax. I thought there's a third heart sound.
There is a typical third heart
Third
sound,
heart
the
sound,
loud sound which you
left
hear.
ventricular failure,
That is
clear
the
third heart
third
sound is
heart.
there. Second sound is loud, very closely split, and the pulmonary component is very loud, right? There is a pansystolic and a mid-diastolic murmur in the
Both are.
apex, and there is a pulsation just below the xiphoid. Put your finger, pulsation. Yes or not? It's there, right?
And also there is a different murmur, TR murmur.
TR murmur.
TR murmur is also.
yes.
So you and S1 is not loud. A
Sir.
loud S1.
Changes it, yeah, it should be soft S1, yes. But I just heard one sound, I was not sure what it was. The loud
It virtually rules out a severe MR.
MR, yes sir. It should be soft S1
Soft
in case,
S1.
in case of MR, which is why I was not sure of the heart.
Where can you get a loud S1 with severe MR?
Yeah.
In other non-rheumatic papillary muscle dysfunction, things like that. Okay.
It's an acquired heart disease, probable mitral regurgitation with mitral stenosis.
At this stage, why do you want to put probably?
Okay. Acquired heart disease. Sir, can I say severe mitral regurgitation?
You say, we will ask you.
Oh, sir. Sorry, sir. Acquired heart disease, severe mitral regurgitation with mitral stenosis, with pulmonary artery hypertension. No signs suggestive of congestive cardiac.
No
Why
signs.
Suggestive of infective endocarditis.
Before that, you put congestive heart failure. You have
Is
all
there
the
cardiac
history.
failure or not? Huh?
Cardiomegaly.
Is
You
there
have a
cardiac
history
failure or
of
not?
leg swelling, facial
Yeah.
puffiness,
With
all
history of
right-sided
cardiac
failure.
No signs of infective endocarditis with growth retardation.
So why do you say severe MR? Don't hyperventilate.
Sir, cardiomegaly.
No, you start from the history. Just the way you present, you start from the history.
History of progressively increasing exertional dyspnea in grade 3. Presence of
So a severity of complaints, grade 3, grade 4 symptoms.
Presence of history of cardiac failure. Then signs of cardiomegaly.
In what form?
In an apex beat which is pushed outwards and downwards. Then associated thrill, a murmur grade, higher grade murmur associated with thrill. Presence of an S3. Presence of pulmonary artery hypertension.
And also associated MDM shows you the severity of.
Associated MDM.
Okay. You said MS? Yes. Associated MS?
Because MDM is present.
How do you differentiate MDM of MS with MR with a flow related MDM?
Presence of an opening snap or
Opening snap.
I don't know.
Okay.
M-
Presence of
M-
opening snap virtually rules out a severe significant MR. So there is no opening snap. S1 is soft.
This one is not.
So it is flow related MDM. So more the severity of the murmur, more severe is the MR.
Grade 4.
What is the differential diagnosis for this boy other than rheumatic heart disease? I'm saying I don't agree with the diagnosis because you said monoarthralgia, no definite history of rheumatic fever. Could this be non-rheumatic heart disease? If it is so, what non-rheumatic heart disease will you consider in the diagnosis of this boy? Anybody in the audience? Cardiomyopathy. In fact, a severe mitral regurgitation, pulmonary hypertension, so much of cardiomegaly, cardiac failure, the closest diagnosis is a one point very much against this being cardiomyopathy. Can anybody tell me what is against this? Huh? No, there is no murmur may very well be there. Murmur of mitral. I think the heart sounds here are not muffled. Of course, it can occur in myocarditis as well as rheumatic carditis as a cardiomyopathy. Here the heart sounds are very well heard. That is very much against a cardiomyopathy. So it favors more of a rheumatic lesion, right? Any other differential diagnosis? Can this be congenital heart disease, congenital mild regurgitation with cardiac failure?
Can.
Huh? Anybody? Congenital mitral regurgitation with rheumatic failure, with cardiac failure, sorry. Extremely unlikely. Congenital mitral regurgitation is a very severe disease which presents right in infancy, which probably will be incompatible with life unless you operate very early in life. Severe, it doesn't present at 8-10 years with cardiac failure. Any other differential diagnosis? What are the other causes of mitral regurgitation other than rheumatic fever, cardiomyopathy and congenital mitral regurgitation?
Autoimmune disorders?
What are the causes of mitral regurgitation other than rheumatic, cardiomyopathy and is this mitral valve prolapse? It doesn't cause so much of a severe mitral regurgitation. If at all there is mitral valve prolapse, it is usually a trivial mitral valve prolapse which may progress later. Right? Anything else? Native wall infective endocarditis. Native wall infective endocarditis, which can explain everything. This mitral regurgitation. Only thing is that boy will have a history of fever, toxemia, etc., which is not there in this boy. Not there. The other conditions which can lead to mitral regurgitation includes your mucopolysaccharidosis, right? And even rheumatoid disease, you can get mitral regurgitation, right? So it looks very, very unlikely in this child. All those things look very unlikely. This looks like a rheumatic heart disease. Okay, final question. Is this child having rheumatic carditis or not at present? Is this child having active carditis? That's a usual exam question. Is this child having active carditis or not?
Or tachycardia?
Is this child having carditis or not? Please say yes or no. If you say yes, explain. If you say no, explain. Anybody in the audience? Nagaveni? Pardon? There. Give the mic to her. Why do you say this boy has got carditis?
Tachycardia.
Yes, Ishita. Why?
Pericarditis in form of chest pain or any pericardial rub. Myocarditis, the heart sounds are very well heard. Myocarditis is unlikely. Pulse volume is very good. The BP is acceptable. There is no evidence, no clinical evidence of myocarditis. Only thing is the valvular murmur, valvular
Very right.
endocarditis.
This child doesn't seem to have any acute illness, and even the history does not suggest that he has had something recently, in the last 1 week, 2 weeks, 4 weeks, suggesting acute rheumatic fever. And more importantly, in the history you can add, he is on regular penicillin prophylaxis, his compliance is good, right? And he is non-toxic, heart sounds are well heard, there is no rub, there is no fever at all. It looks very, very unlikely that he has got an acute carditis. But however, one statement is worth remembering. In a child with an established rheumatic valvular disease, any deterioration should be thought to be due to rheumatic carditis unless proven otherwise. Right? And more importantly, for a diagnosis of rheumatic fever in a child with a pre-existing heart lesion, you don't have to have all the criteria. And this is how you should be able to defend yourself, saying that this could still be carditis, but it is not likely. Right?
Indolent carditis is quite common, wherein you don't have indolent carditis is quite common in our part of the country. I mean, in our country, wherein you don't have florid clinical pictures. I mean picture, but you still have carditis, underlying carditis.
What do you do? What do you do for him now?
So,
Set up.
the investigations, complete blood count check for total counts, check for any inflammation.
How do you interpret the complete blood count of this boy?
He can have anemia, he can have increased total counts, increased
Right?
here we can check the ESR and CRP to check for any.
What do you expect the ESR and CRP to be in this boy?
ESR should be raised anywhere between above 30 to 60.
In this boy, you expect a normal ESR or a raised ESR?
In this boy, unless you think of carditis, you can have a normal ESR.
What happens to ESR when there is anemia?
It's raised.
Increase. What happens to ESR when there is cardiac failure?
It falls.
False. So remember the fallacies, right? In a child who has got a cardiac failure, the ESR may not be very high. In general, CRP is more useful as a acute phase reactant even in rheumatic fever. Okay? It takes shorter time for it to go up and shorter time for it to come down. It is not affected by cardiac failure or by hemoglobin. So that's the advantage of CRP. What else will you do?
We can take a blood culture to rule out any infective endocarditis.
This boy, you want to do blood cultures?
No history of any fever.
So I don't think it is necessary unless the echo done by Dr. Gnanasambanam suggests that there are new vegetations. Otherwise, I don't think we need to do, or you document fever in them. We don't need to do a blood culture.
Chest X-ray to see cardiomegaly.
Before chest X-ray, suppose you want to prove that this is rheumatic fever.
Rising ASO titers.
ASO titer. What do you mean by rising ASO titer?
So, single ASO titer more than 333 is considered significant, but much more significant is a rising ASO titer across 4 weeks.
ASO titer is normal. Does it rule out rheumatic fever?
Anti-DNSB also.
Anti-DNSB. Do you do it here? You don't do. Anti-DNSB is, what is the difference between ASO and anti-DNSB? Anybody? The only difference is anti-DNase, the titer lasts for a longer time than ASO. Right? So, it doesn't make much of a difference. If both are positive, in fact, there is what is called streptozyme test which came into the market, now nobody does it. And there is very little reliance on ASO titer because it has got several false negatives and positive. For example, you do after about 6 weeks, ASO may not be high. And in a country where there is a lot of streptococcal pharyngitis, ASO can be elevated. That's why the cutoff is 320 in India, and other centers it may be lower. Depends on the endemicity of pharyngitis, right? What else will you do?
ECG?
You do a throat swab culture for him?
Yes.
For this boy today?
No.
And suppose you suspect rheumatic fever, worthwhile doing to prove streptococcal infection. In fact, in the recent what Dr. Jnanasambandam quoted, the circulation article May 2015 has included even rapid tests as one of the evidences for preceding streptococcal infection. In addition to culture and ASO, they have included that as one of the criteria for preceding evidence of streptococcal infection. What else will you do?
ECG and echo.
What do you expect in the ECG in this boy? In rheumatic fever, what will you expect? In this boy, what will you expect?
Rheumatic fever, I'll expect a prolonged PR interval. In this boy, he has
Or heart blocks of varying degree. Heart blocks of varying degree, right?
this. In this boy, I might look for suggestive of right ventricular hypertrophy.
You expect right ventricular hypertrophy in this boy or
Biventricular
You
hypertrophy.
expect biventricular hypertrophy. His
Atrial,
apex is in the
left
sixth.
atrial enlargement and
Yeah.
biventricular hypertrophy.
Right. X-ray.
X-ray suggestive of cardiomegaly.
Yeah, what do you see in the X-ray?
Sir, cardiomegaly with a downward and outward apex.
How do you differentiate right ventricular hypertrophy? I mean enlargement with from left ventricular enlargement.
The apex is shifted up in right ventricle, and in left ventricle it is downwards and outwards.
Okay, this is typically in which view? AP or PA?
PA.
Okay.
Three 3. Yes, sir. This is last year itself, sir. This is 2014. No, this is 4th month. This is 3rd and 5th. This is 3rd month, this is 4th month, and this is 9th.
Last year.
2013, 2014, 2015.